Hello, this is the second of the series on atherosclerosis. We're going to start with historical epidemiology. Just as a quick recap, atherosclerosis has moved on from the lipid hypothesis to include the fact that inflammation also plays a significant role. It's moved on from the vulnerable plaque to the vulnerable patient. Historically, the London Transport Study in 1953 was pioneering work done by Jerry Morris. He studied a cohort where he compared bus drivers that were sedentary to bus conductors that were highly active, climbing up and down stairs. Key finding was that active conductors experienced roughly half the rate of heart attacks compared to sedentary drivers. This confirmed the behavioral factors profoundly modulate the internal atherosclerotic process. Established cardiovascular risk factors include non-modifiable risk factors such as age, gender, and genetics, such as familial hypercholesterolemia, modifiable risk factors such as dyslipidemia, including elevated LDL-C, a low HDL, hypertension, such as chronic high blood pressure that damages the endothelium and promotes wall stress, smoking, that is, tobacco toxins cause endothelial dysfunction, inflammation, and prothrombotic effects, doubling coronary disease roughly, diabetes and metabolic syndrome that accelerates atherosclerosis via lipid problems, and hyperglycemia. The lipid problem coexists with the sugar problem, and hyperglycemia induces endothelial damage and inflammation. Lifestyle, including diets high in saturated trans fats, obesity, and sedentary behavior. All of these contribute to atherosclerotic risk process. Moving on, the traditional risk scores are insufficient to capture subtle plaque change. Quantitative coronary angiography, invasive measures of luminal geometry, such as minimal luminal diameter percent stenosis, combination of coronary CTA and quantitative CPA non-invasively measures the entire arterial wall, total plaque volume, non-calcified plaque volume, calcified plaque volume can all be estimated. Preferred endpoint is a non-calcified plaque volume to measure intervention efficacy. Non-calcified plaque volume is the preferred endpoint because it measures active plaque. Calcified plaque is likely inert plaque. The earlier change is the non-calcified plaque, and it better reflects the treatment effects. And there's a stronger correlation with events, as mentioned in the infographic. Quantitative coronary angiography evidence, exercise reduced post-intervention restenosis. The study focused on patients undergoing PCI who enroll in cardiac rehabilitation. Key metric was late luminal loss, a quantitative coronary angiography measurement of restenosis. Quantitative finding, the cardiac rehab group had late luminal loss of 0.16, which was significantly lower than the control group who had a late luminal loss of 0.39. In conclusion, exercise plays a potent direct biological effect on the local vessel wall, delaying restenosis in patients with stents. The Mark II study measured an athlete's risk of cardiovascular events. The key finding was exercise intensity but not volume was associated with plaque progression over 6 years. It's a dose response effect. Vigorous exercise 6 to 9 METs hours per week was associated with less coronary artery calcification or progression. Very vigorous exercise, more than 9 MET hours per week, was associated with greater progression of calcified atherosclerotic plaque. Now, this could be considered as a U-shaped curve with those having less exercise, having more plaque, and those having more exercise, having more calcified plaque. So, could exercise be too much of a good thing? Let's see. When you measure quantitative progressive metrics such as very vigorous exercise, this was associated with statistically increased odds of plaque progression. Calcified plaque specifically progressed. The odds ratio was 1.09 for progression and um, 1.07 for increased number of plaques. There is a difference in the quality of the plaque. Moderate to high endurance exercise was associated with low high risk plaque and reduced non-calcified plaque burden. This interpretation of the calcification should be taken in context of this. The increase in calcified plaque volume at very vigorous exercise intensities is hypothesized to represent plaque stabilization. Mechanism is unclear. Exercise may increase maturation, converting vulnerable non-calcified plaque into dense, mechanically stable calcified plaque. So to figure out the safe amount of exercise for somebody that plans on exercising, you list your weekly sessions, you list the intensity in METs, you convert to MET hours per week, and then decide. For example, a brisk walk is 3.5 to 4 METs, easy cycling is 4 to 6 METs, easy swimming is 5 to 6 METs, vigorous exercise like steady running 7 to 8 METs. The height classes are 7 to 8 METs. Very vigorous exercise would be more than 9 MET hours per week. So this is an interesting table. If the exercise level is moderate to high or very vigorous, the let me just get a pointer here. Very vigorous exercise more than 9 minutes is associated with low high risk plaque, with a low non-calcified plaque and increased calcified plaque, likely representing stabilization. Moderate to high vigorous exercise has low high risk plaque, low non-calcified plaque, and a mild increase in calcified plaque. The sedentary patients have high risk plaque, high non-calcified plaque, and low calcified plaque. This is an interesting finding. Plaque stabilization. So plaque starts as a soft, lipid-rich, non-calcified. Exercise-induced stress leads to healing and ends in dense, heavily calcified plaque. Structural stabilization. Exercise increases fibrous cap and reduces pro-degradation enzymes like metallic metalloproteinases. There's anti-inflammatory effects where it decreases chronic vascular inflammation with necrotic factor alpha. Calcification mechanism is hypothesized to stem from chronic high magnitude hemodynamic stress accelerating microcalcification. Another emerging risk factor is lipoprotein little a. It's genetically determined LDL-like particle, which is pro-atherogenic, pro-thrombotic, pro-inflammatory. It's a strong independent predictor of atherosclerotic cardiovascular disease. Novel therapies such as antisense oligonucleotides and pelacarsen, which is a mRNA silencer, are in clinical trials. Another emerging risk factor is chronic inflammation and CHIP. Inflammation is a risk factor. High sensitivity C-reactive protein independently predicts cardiovascular events. In the CANTOS trial, use of canakinumab reduced significant recurrent heart attacks. Low-dose colchicine is used in secondary prevention. The clonal hematopoiesis theory was outlined in lecture 1. Age-related expansion of mutant blood cell clones. TET2 is an independent risk factor for atherosclerotic cardiovascular disease, driving low-grade inflammation, and these markers increase with age. So in essence, LDL loads a gun and plaque rupture pulls the trigger, and inflammation, chip, etc. might be involved in the trigger mechanisms. Another emerging risk factor is gut microbiome and environmental risk factors. The gut microbiome dysbiosis results in production of TMAO, trimethylene N oxide, which is linked to higher rates of heart attack and stroke. Environmental exposure to PM 2.5 triggers systemic oxidative stress, inflammation, and increased heart attacks. Heavy metal exposure such as arsenic, lead, cadmium increase oxidative stress and vascular damage. Psychological stress is not just psychological, it elevates cortisol, leading to higher blood pressure and endothelial dysfunction. So this infographic goes over the emerging risk factors and points out the relative respective um, mediating agents. For example, gut dysbiosis via TMAO, air pollutants via PM2.5, heavy metals via vascular remodeling, chronic stress via cortisol. Now, moving on to advanced and lipid-lowering therapies, PCSK9 monoclonal antibodies lower LDL with an additional 60% drop on top of statins. Inclisiran, an RNA silencer, silences the PCSK9 gene and provides long-lasting LDL reduction with more than 50% decrease with twice-yearly dosing. Bempedoic acid is an oral non-statin that inhibits ATP citrate lyase and reduces LDL by 20%. Upcoming are pelacarsen, which promises to be the first targeted therapy for Lp(a). Gene-based innovations include use of CRISPR to knock out PCSK9, and in future there's precision medicine coming up with targeted genetic and immunomodulatory therapies. Another important thing to consider is social determinants of health, lower socioeconomic status, and reduce access to care. Social determinants of health are important on account of environmental exposure to different pollutants, poor access to care, poor access to diet, and it has been shown that one-third of cardiovascular mortality in America is explained by socioeconomic status and digital illiteracy. Thank you for watching.